Hello, my name is Deepika Shaligram. I'm an attending psychiatrist at Boston Children's Hospital, Harvard Medical School, and a member of the Family Committee of the American Academy of Child and Adolescent Psychiatry. I will be discussing attachment disorders. Children have a basic biologically rooted need to form a lasting bond with their caregivers. The parent-child relationship is the first crucial relationship that an infant forms, and the health of this relationship has a profound effect on a child's social and emotional development. Studies of normative development suggest that clear selective attachment bonds become evident sometime between the ages of 6 and 9 months. This is indicated by preferential seeking of comfort from the primary caregiver, distress triggered by being separated from the caregiver, and stranger wariness. Children who form secure relationships with their primary caregiver have fewer internalizing and externalizing behaviors. They are more socially competent and better able to regulate emotion and stress. They exercise better self control. Conversely, children with insecure attachments have a greater likelihood of physical health issues and impaired social, psychological, and neurobiological functioning extending into adulthood. Interestingly, even if the relationship with the primary caregiver is strained, a child has the capacity to form attachment like relationships with other caring adults. For example, the teachers. Bowlby, the father of attachment theory, suggested that when children are raised with confidence that their primary caregiver will be available to them during critical moments of stress, they are less likely to develop future internalizing symptoms. In the 1970s, Mary Ainsworth described three major styles of attachment based on the strain situation experiment in children aged 12 to 18 months. They were secure attachment, ambivalent insecure attachment, and avoidant insecure attachment. A fourth attachment style, called disorganized insecure attachment, was added by Main and Solomon. Research has shown that parents of securely attached children tend to play more with their child and are generally more responsive to their child's needs. Ainsworth highlighted the importance of parental sensitivity in forming secure attachments. Parental sensitivity is influenced also by systemic context. Poverty and other social determinants of health, family stressors, a caregiver's personal history, and the marital relationship all represent modifiable risk factors. Attachment disorders have a prerequisite for pathogenic care. Pathogenic care refers to a persistent disregard of a child's emotional or physical needs or repeated changes in primary caregivers, as often happens in foster care or institutional care. Reactive attachment disorder has an onset before the age of 5 years. It refers to a consistent and pervasive pattern of extremely withdrawn behavior, a marked tendency to not show attachment behavior towards caregivers, accompanied by a general lack of responsiveness to others, a limited positive affect, or episodes of marked sadness, fearfulness, or irritability. Disinhibited attachment disorder, also called the disinhibited social engagement disorder in the DSM-5, refers to a marked and pervasive tendency to not show appropriate cautiousness with strangers, a failure to be sensitive to social boundaries. Examples include going off willingly with a stranger with no hesitation, being overly familiar in verbal and physical interactions with a stranger, and limited checking back to a caregiver when in a new situation. Assessment of attachment disorders occurs with structured interviews with caregivers, supplemented by questionnaires and direct observation of child behavior. Attachment may be indirectly assessed by examining the primary caregiver's sensitivity to the child, especially in moments of distress. An estimated two-thirds of children in population samples have a secure pattern of attachment across cultures. This falls to one-third in disadvantaged child populations. About 15 to 19% of population samples and 40% of disadvantaged populations are thought to have disorganized attachment. This number rises to 80% in maltreated child populations. Reactive attachment disorder and disorganized social engagement disorder are seen at substantially higher rates amongst children raised in institutional care or exposed to severe abuse or neglect. Attachment patterns in infancy show some stability over time, but they are also open to change in response to changes in caregiving. Later attachment outcomes are related to familial experiences occurring across childhood. For example, quality of caregiving, divorce, and parental well-being. Attachment difficulties not only make a child more anxious or aggressive, less able to comfort themselves, but it may also affect a child's neurological development, attention span, and ability to form social relationships. The overlap in symptoms between attachment difficulties and neurodevelopmental conditions like ADHD or autism spectrum disorder highlights the importance of exploring attachment and trauma issues before making these diagnoses. Meta-analysis suggests that around 55% of children with oppositional defiant disorder or conduct disorder have insecure attachment. Reactive attachment disorder is associated with an increased prevalence of anxiety disorders, while disorganized social engagement disorder is associated with both increased risk of internalizing and externalizing problems. Tips for adult psychiatrists. If we conceptualize attachment difficulties as a marker of maltreatment within the family, then the child's behavior can be understood as a survival response that, if left untreated, becomes hardwired as a stress reaction. Treatment of attachment difficulties involves both the child and the family. Simple strategies that can be offered by adult psychiatrists is to help caregivers to notice and respond to the child's nonverbal and verbal cues. With young children, this may include sharing emotions, turn-taking, mirroring the infant's emotions, helping the infant with strong emotions, and recognizing the infant as an individual whose communication matters. Seeking support from social welfare and safeguarding agencies and consultation from child mental health professionals is important for adult psychiatrists when issues of attachment difficulties arise. Safeguarding is the action taken to promote the welfare of children and to protect them from harm such as abuse or maltreatment. Reviewing the local general medical council's guidance can assist in making a decision about safeguarding or mandatory reporting. Since caregivers may have a mental, physical, or social situation affecting their ability to respond to a child's needs, it is important to screen for and treat any caregiver illness. The NICE guidelines stresses the importance of a case management system to coordinate care and treatment, which includes referral to child and adolescent mental health services, community pediatricians, or social services. A multidisciplinary approach may include involving the school and health visitors, and for young infants, the community midwife or non-governmental organizations. Health visitors and children's social care agencies may triage the situation and offer appropriate supports like parenting and behavioral interventions. NICE also emphasizes that the school has a role in reducing exclusion and monitoring for absences. Many of the evidence-based interventions focus on improving parental sensitivity, and they are tailored to a child's developmental stage and particular needs. Home visiting programs assess and address caregiver-child relationship. Caregiver-child psychotherapy is another treatment modality offered by trained mental health or social work professionals. Close and ongoing collaboration between the child's family and the treatment team will increase the likelihood of a successful outcome. In summary, attachment difficulties constitute a common modifiable risk factor for mental health problems. Only in extreme cases of grossly inadequate or unstable care do attachment difficulties constitute a medically diagnosable mental illness. Attachment difficulties are likely to be reduced by supportive family environments and interventions of mental health and social welfare practitioners. There may be symptom overlap between attachment disorder and neurodevelopmental conditions such as autism spectrum disorder and ADHD. Social circumstances such as poverty, inequities, caregiver mental illness can all be targets for intervention when a child presents with attachment difficulties. Further, parent-child interventions, referral to child and adolescent mental health services, and primary care and child protective services all play important roles in treatment. For further information, please consult the Attachment Disorders Facts for Families and the American Academy of Child and Adolescent Psychiatry's website, acap.org. NICE guidelines of 2015 also discuss children's attachment. Thank you for listening.